Thank you very much, Harry, and a pleasure to be here, and thanks to the organisers for inviting me. I'm not a mental health specialist, so I should say that up front, and I'm going to say many things that are probably going to surprise you, but please forgive me. My area is, as Harry mentioned, more in the quantification of health, and I'll talk a little bit about why we do that, and one of the key variables in quantifying health is the comparative importance. Again, I will speak a bit more about that, of different conditions. And as Harry mentioned, the burden of disease, when Chris Murray and I first did it almost 25 years ago, was surprising to many people, because what it did was bring up the importance of some hitherto, I think, major neglected areas in global health, including mental health, but also including injuries. So today, what I want to do is, I don't have a lot of time. There are 1 billion results in the global burden of disease, and I'm not going to show you 1 billion results clearly in 25 minutes, but what I'd like to do is to give you an overview of what burden of disease is about, why I'm here talking to you, and why it might be important for your work and your conference, and then some of the findings at the global level, the higher order findings at the global level that I think are important for, as the title of my talk mentions, about global health and development, not just for mental health, but for health development more broadly. So firstly, what is the global burden of disease? I'm sure many of you are familiar and you've seen many of the publications, but we like to think of it as a systematic scientific effort. Several of you in this room, for example, Harvey Whiteford, who's going to follow me, led much of the work on certain areas for burden of disease. And the principles that every group followed was really quite rigorous, often unpleasant at times, because Murray and I and others who were leading the project insisted that this went to the highest possible scientific standards. Difficult because the availability of data is quite sparse, as you're no doubt aware. Some of the results I'm going to show you, you're going to throw your hands up and say, how on earth did they measure depression in Mali? And that's a fair question. So in order for us to cover ourselves and to make this a scientific effort, it follows some systematic scientific principles. Keywords here are comparative. I mentioned that in my introduction. What the burden of disease does is it takes conditions and it says, we know that tobacco is harmful for you. We know that depression is a major cause of health loss. But what does that mean? What does depression mean in terms of health loss from measles, malaria, or TB, and so on? So it's that comparative dimension that is important in terms of objective policy dialogue. It measures health loss. It does not measure welfare loss. We've been roundly criticised for this, but we defend it. We are health Nazis. We are interested in measuring the health loss from various conditions in populations, not the welfare loss. So many of the conditions, for example, substance abuse conditions, have extremely important externalities. They affect people other than the person suffering the condition. But we are measuring the health loss of people with conditions. So it's measuring health loss. We do that, I'll show in a moment, using DALYs. You can't just do burden of disease for one or two conditions. It is of no policy value whatsoever for us to quantify measles and malaria. May be useful for those communities, but it is no use to the broader public health community. So we've chosen 291 diseases, 1,160 sequelae of those diseases, 67 risk factors for 187 countries, for 20 age groups, for 2 sexes, and in the case of mortality for 30 years, in the case of burden of disease for 3 years, 1990, 2005, 2010. I say 1990 because we have gone back and recalculated the burden of disease for 1990 so that it is comparable in time to what we've calculated for 2010. A couple of key principles. I've mentioned the importance of comprehensiveness. You can't just quantify the conditions that are easy to quantify. For public policy, you need to quantify a vast number of conditions. We believe that informed estimates are better than no estimates, because often in public policy, no estimate equals no problem. If we don't have an estimate for schizophrenia, well, it falls off the global debate. So what we want to do is wherever we can and everywhere we can, we measure burden of disease. I'll show some of the methods in a moment using covariates. And comparability is extremely important. That it is very, very important for public policy, both globally and in countries, to understand whether depression is a greater cause of health loss than tobacco or some of the other conditions that are prominent in health debates. And we do this across countries, across time, by age and by sex. So quickly some of the terminology. I won't give you a lesson in calculus. There's an awful lot of methods behind this, but essentially we measure two things. We measure premature mortality. And remember, what we're trying to do here is get a single summary measure of health loss. So we need a framework in which we can combine mortality and disability. We do not talk about morbidity in GBD lexicon. We talk about disability. And we do that in two ways. We calculate years of life lost by just simply taking the age distribution of deaths from a cause and weighting that by the potential years of life lost using a standard global life table. And for disability, somewhat different to what Murray and I did in the first burden of disease study, we simply take the prevalence of disability from those 11 60 sequelae and we weight by a disability weight on a scale of 0 to 1. 0 perfectly healthy, 1 being equivalent to dead. And then DALYs are simply the sum of those two time-based into the future measures. YLLs and YLDs give us disability-adjusted life years, or DALYs. I've mentioned we don't talk about morbidity. So, for example, if someone has the flu and is incapacitated for 4 or 5 days, many of you had the flu, you know what that's about, that's a form of disability. It's a form of health loss. And we calculate it and quantify it in that way. Now, importantly for mental health, in the 2010 GBD study that I'm going to show the results for, we did not use age weighting and we did not discount. This has had a big impact on the absolute value of mental health DALYs. It's had a lesser impact on the relative importance, and they still come out very importantly, but I want to be very clear up front. After much debate with philosophers and ethicists over the last 5 to 10 years, we have concluded that age weighting and discounting do not have a strong basis, and so we have not used them. This is a simple diagram of the doesn't look simple, but it is simple. There's 18 boxes. Each one of these boxes has another 15 to 20 boxes behind it to show that this is a 5-year endeavour of about 1,000 people working away. Now, for example, one of these boxes, we had a whole team working just on measuring mortality by age and sex for 187 countries. Another block of people, these yellow boxes, on estimating causes of death. About 70% of DALYs come from causes of death, so it's really important to try to get them as right as you can. A whole block of DALYs on non-fatal, what we call the non-fatal descriptive epidemiology, and in this case many of the mental health conditions fall into that block of non-fatal, very important contributors to DALYs. They contribute to years of life lost and YLDs, which together contribute to DALYs. On the left-hand side here, a whole block of work has been done on risk factors, because for public policy, it's important not just to have an accounting, a categorical attribution of disease burden in a population, but you really want to know what causes disease burden. And I hope at the end of my talk I'm going to ignite some enthusiasm among you for the risk factors that are associated with mental health. We don't know these, at least in the global burden of disease community. We don't quantify them because we don't know them. We have many risk factors for heart disease, stroke, cancers and so on, but we're not doing so well for mental health and injuries. But just to show that the two outcomes of the study are DALYs attributable to conditions and injuries, including mental health, and DALYs attributable to risk factors which underlie those various conditions. We did not do this alone. The first GBD study, Chris Murray and I did in a barn in Maine in the United States when he was at Harvard, and it's not recommended that two people try to it's not a replicable methodology, put it that way, and it's the reason my hair is grey. This time what we did is we worked much more collaboratively, and I'm pleased to say many of the colleagues we worked with are in the room today, or several of them in mental health. About 500 authors from 300 institutions, and they're in these countries in green. And notice it's not just a US, Canada, Australia, Western Europe. There's a large number of collaborators that we were able to involve, particularly from East Asia and Latin America. In the rest of this talk, I'm just going to to focus on a few key things, some of the outputs then of burden of disease, what are some of the higher order implications. Some of this may be a bit boring because it's not directly related to mental health, but as mental health specialists, you're part of the global health community, and I think it will be useful for you to understand what we found in terms of global health, in terms of mortality, disability. I'll look at very briefly DALYs, I'll talk a bit about risk factors, and then what I think some of the implications are for global health and development. And important, I'm sorry about the lighting here, but this is a graph to show over the last 20 years, from 1990 to 2020, the decline in risk of death for females in red and males in green by age. A couple of key points. Look at this huge decline in child mortality over the last 20 years. We've been remarkably successful in avoiding child mortality. We haven't finished, but we've been very successful in bringing down the risk of child death by 2/3 over the last 20 years. All those programs are working. And even into old age, well, sorry about that for the people in the room, but as I get older, I'd like to push that definition of middle age up a little. But up until age 75, forget about 80 because that's contaminated by age structure, but up to age 75, look at this, the 40% decline, 40 to 45% decline in age-specific mortality for women is an impressive achievement. It's not just in middle-aged women, but also in older women as well. Now, for men, it's a little less impressive. What's much less impressive is this, if you can see it, big drop there in mortality, very modest declines, very, very modest declines in mortality over the last 20 years for young adult males, and we can talk a little bit about what the causes of that might be. In terms of child mortality, this graph, the key thing I want to show you from this graph is not that each of those colours represents a level of child mortality in the year 2010. Red is bad, with a risk of a newborn child being dead before his or her 5th birthday, 10% or more. It's about 0.5% in Australia, Australia being in the darker colour there with the United States and Western Europe, Canada. But Africa still has much of Central Africa where a child has a greater than 10% chance of being dead before his or her 5th birthday. But much of Asia, the lighter green here, much of North Africa, much of Latin America, and some parts Chile and Uruguay, levels similar to Australia, have had huge declines in child mortality over the last 20 years. And we can see that globally. I mentioned earlier we should all rejoice in these big declines in child mortality, but we should not take our eye off the unfinished agenda. And that unfinished agenda in 2010, down here, if we go across, there's still around 7 million children a year who die before their 5th birthday, substantially less, though, than 1990, when that number was 12 million. So that, I think, is a huge success for global public health. I've shown several estimates of this, not because I want to show that we're all in the same ballpark, but just to show that the speed of decline of child mortality as we get closer to MDGs, MDG 4 is reduction in child mortality by 2015. Notice that the speed of decline for the more recent measures, the GBD in particular, shows that that's accelerating. So while many countries may not achieve MDG 4, we should not be punishing them for that. We should be applauding the rapid declines in child mortality that we're seeing, including Sub-Saharan Africa. What is much less comforting for global health is adult health. And it's not just non-fatal adult health from mental conditions. This graph shows the risk of I've chosen males, it's somewhat similar for females, a bit less extreme, the risk of a 15-year-old male anywhere in the world being dead before his 60th birthday. Now, everyone in this room must agree that that's premature mortality. It's not just about child survival. There's an important global agenda about keeping babies alive to adulthood, but keeping adults alive into old age. And how well are we doing? Well, not very well. Look at all this red here. Red means that a male will have a 45 to 50% chance, 1 in 2 chance, of dropping dead before his 60th birthday. Russia, neighbouring countries in Eastern Europe, this is the alcohol epidemic. The alcohol epidemic in Russia and neighbouring countries, particularly since the end of the Gorbachev era. Massive increases in mortality we see there. And then you see red down here in sub-Saharan Africa, and that, of course, unfortunately, is the HIV epidemic. So much of Africa, still high levels of adult mortality, whereas countries like Australia, notice Canada and the United States, I think we have representatives from both in this region. Canada, always on health measures, is doing better than its southern neighbours. Australia, Japan, some of Western Europe, and also, interestingly, some of North Africa now have relatively low levels of adult mortality. But again, great global diversity in adult mortality. In terms of life expectancy, again, I don't want you to be able to read the graph. I want you to appreciate the different colours. Blue is good, and it shows over a 40-year period that we measured from 1970 to 2010. Dark blue here means countries had a gain in life expectancy of more than about 25 years. Very impressive declines in mortality. This is for males, but it will be similar for females, if not more impressive. In much of the Middle East, countries like Oman have had huge declines in mortality. Countries in Latin America and even Australia, Canada, to some extent the United States, to some extent much of Western Europe, with relatively low levels of mortality, high levels of life expectancy 40 years ago, have continued to enjoy gains. I'll move on now to causes of death. As I mentioned, causes of death underlie an awful lot of what we measure in burden of disease. For the GBD study, we had 750 million observations on causes of death worldwide from vital registration in various sources, and we list the sources here. Much of it comes from vital registration. For 130 of those 187 countries, we were able to identify some data on causes of death. We used verbal autopsy in much of much of Africa, where we couldn't get vital registration, cancer registries, police reports, even mortuary reports as well. So quite a vast amount of data, but the key thing about mortality that I didn't show in those boxes is even though we have information on causes of death for America or Australia or France, we still need to apply a critical lens to it because doctors often get the underlying cause of death wrong. And so we do need to apply certain methods that we've developed in the burden of disease for correcting what we call garbage codes. Not very elegantly described, but that's what they are in terms of public policy value. Now here's the big picture over the last 20 years, from 1990 to 2020. The blue there, this is total deaths. In 1990, 46.5 million people, we estimated, died worldwide. By 2010, that was almost 53 million. So an increase of 6 or 7 million over that period. What's more important is not so much the increase in the size, but the increase in the colours. So non-communicable diseases, which cause 57%, we estimate, more than half of deaths already in 1990, by 2010 caused two-thirds. Two-thirds of deaths in the world today are due to non-communicable diseases. Pleasing declines in communicable, maternal and nutritional from about a third to a quarter. Injuries have not changed. In fact, they've gone up slightly. 1 in 10 deaths worldwide currently occurs from injuries. Now, you can't possibly see that, and I apologise for the quality of the slide, but what I'm trying to show here are the leading causes of death in 1990 and 2010. By the way, if you go onto the IHME website, you can see all of these animated live. But ischemic heart disease and stroke were the leading causes of death in 1990. They're the leading causes today. Chronic lung disease went up from 4th to 3rd. Some important declines here. Protein energy malnutrition dropped dramatically. HIV, the big one that comes here, 33rd leading cause of death in 1990. HIV/AIDS is now the 6th leading cause of death, just behind lung cancer. Notice lung cancer, pneumonia, COPD, stroke, ischemic heart disease. The common risk factor for all of those, with the possible exception of pneumonia, is tobacco. And we'll talk a bit more about the impact of tobacco. Body counts are important for public policy, but they are not that important in the sense that we would all agree that saving the life of a 5-year-old is probably going to be of greater societal value than saving the life of a 95-year-old. I apologise to the 95-year-olds in the audience, but that's how we describe it. So we use this measure YLLs, this measure of premature mortality, and this shows a very similar and again, very difficult to see, but I just want to point out that the leading cause of premature death worldwide today is not pneumonia, it's not diarrhea, it's ischemic heart disease. So ischemic heart disease is prevalent and rising from the 4th to the 1st leading cause of death worldwide, followed by pneumonia, stroke, diarrhea, malaria, HIV, preterm births, road injuries, chronic lung disease, and then TB just out of the top 10. A really important, interesting mix of what we called old world and new world diseases. Now, again, I'm not going to test you on how much of this you can read, but I just wanted to convince you that those boxes I showed earlier, each of them have several sub-boxes. These are all the work that we did using various data sources, cancer registries, case notifications, active screening, ANC seroprevalence. All of this was done to estimate what we call the YLDs, or the non-fatal part of disease burden. This is very difficult to do because we're not bounded. Remember, for causes of death, people can only die once. And so if we have good demography, we know with some degree of confidence the numbers of deaths by age and sex in different countries. We have a automatic natural boundary on the claims for causes of death. We don't have that for non-fatal diseases. And so what we've done is develop this model called Dismod. It's a meta-regression method. Murray and I developed this years and years ago, what we call the old Dismod clunker, which effectively forces an epidemiological consistency between incidence, prevalence, case fatality, duration, and mortality. It just makes sure that they're all internally consistent, so you cannot have more less incident cases than you have prevalence. So there's a logical relationship between the two. I won't go through Dismod, but the key point here is the internal consistency between those various epidemiological parameters. This has saved us because we've been able to take what's often very scrappy information. What's available on schizophrenia worldwide in your countries? And just think about what's available. You need incidence, prevalence, case fatality, remission, and mortality by age and sex. Do you have all of that in your countries? No, you don't. And so you have probably some reasonable prevalence data. What we need to do is extract truth from prevalence using this Bayesian meta-regression analysis. There's a whole book on it and various papers, but I just wanted to show you. And these are some of the results for some of the conditions. This is alcohol dependence over here. The bars here indicate the data from prevalence studies. I'm not sure what region this is for. This is Australasia. Data from prevalence region studies. This is age group along here. And the dark blue there is what Dismod does in terms of trying to best estimate using covariates and meta-regression. The dark blue line is the actual prevalence by age of alcohol dependence that we've estimated from the Australian data. Here we have alcohol dependence. This is incidence, remission, and so on. So you'll see remission is quite high in some age groups, falls off. These are the various outputs from Dismod, just to show that we the methods. Now, that's all I'm going to talk about on methods. What I want to do is show, and again I apologize for the lighting, but this is a graph of by age from 0 up to 80 plus. This is for the world in 2010 to show that what kills you, those leading causes of death, don't actually have a strong relationship to the other important dimension of measuring health loss in populations, namely disability. And here's a graph of the most important causes of disability by age worldwide. The light green here, the yellow and light green, which are particularly prevalent from about ages 15 right through to about ages 45, those are mental health conditions. So if you looked at that graph, as those of you at the back, what you can see, there are two prominent colours, the light green and this what's called a light purple, which doesn't show terribly well. The light green are mental health conditions. Notice they start young and they go right through to important causes of disability right through to about age 55. And the light ones here are musculoskeletal, which get increasingly important as you get older. So two very big areas of health loss in populations. Mental health conditions, musculoskeletal conditions, and then the dark green, which is much bigger in 2010 than it was in 1990, are the complications of diabetes worldwide. So those show you the leading causes. I'm sorry, again, keep apologising. These are the main causes of years of life lost, YLDs, from mental health conditions. This colour here, which is actually a light blue, one you can hardly see, are major depression. So the major cause of YLDs, as you're probably familiar with, are major depression. The dark blue are anxiety disorders. This is also by age. These are the age groups about 10 to 40. Bipolar disorder is in the dark blue. But depression, the main cause. Schizophrenia, by the way, is the yellow down here. Seemingly important, particularly from about ages 30 through to about age 60. So those are, Harvey will drill down more if I ever give him some time to talk on those mental health conditions. But put together then premature mortality and YLDs. If you're Gro Harlem Brundtland, or today it's Margaret Chan, it's Gro Harlem Brundtland when I was there, you wake up every morning, the Director General of the World Health Organization, what are the leading causes of health loss worldwide? What should you be concerned about? What should WHO be driving in its agenda? Well, the leading cause of DALYs, this is premature mortality and non-fatal, worldwide in 2010, ischemic heart disease, up from 4th cause of DALYs to 1st cause of DALYs, the leading cause of health loss worldwide. Second leading cause is pneumonia, stroke, diarrhea, HIV, low back pain. Low back pain? Doesn't kill anyone? Anyone here ever had low back pain? Prevalent, disabling, and can be quite long duration. So it has all the parameters to get lots of DALYs. Low back pain, malaria, COPD, road injuries. 11th, just outside the top 10, is major depressive disorders, and a little bit further down come anxiety, the two leading causes of DALYs. It's very hard to see from there, but just what I wanted to show was the change in DALYs worldwide over the last 20 years from mental health disorders. Red means that there's a change in rates. Blue is a change in DALYs due to population growth and composition. And I think the two key ones I want to point out, huge increase in rates, epidemiological increase, not just demographic increase, in DALYs, contribution of DALYs from eating disorders, and a very substantial increase in DALYs worldwide from drug use disorders. That's what we're able to measure with our colleagues. Be important to see how that goes. Interestingly, depression's had a minor change, a minor decline, but a significant drive down from population aging. So finally, just to summarize those main points, mental and behavioral disorders caused 7.4% of global DALYs in 2010, 5.4% in 1990. In other words, if all of the world had no mental health conditions, globally the world would have been 7.5% healthier in 2010 than it was. That is a significant contribution. The major drivers of population are population growth and aging, as I showed on that graphic, with a couple of exceptions. There's a minor increase in DALY rates overall. Overall, 6% increase in DALY rates from mental health conditions. But notice for things like drug disorders and eating disorders, that is significant. The leading contributions come from major depressive disorders, 2.5% of global DALYs, anxiety, drug use, alcohol, and schizophrenia. What I wanted to make the point, though, because I haven't done this very well in terms of comparative importance, the DALYs from mental health, 7.4%, are equivalent to global DALYs from all cancers and equivalent to global DALYs from both HIV and TB combined. Now think of the massive research, massive global public policy responses for cancer and HIV and TB, and yet this community has an identical volume of DALYs. I also wanted to point out that the DALYs are lower in this study than we measured for the GBD 1990 study, largely due to the impact of the measurement metric. In other words, we did not weight and we did not discount. There's something on risk factors I really want to move very quickly because I am taking time up, but dietary risks, high blood pressure, and tobacco. This is the risk factor contribution to global DALYs worldwide. Dietary risks, if we all ate the Mediterranean diet worldwide, global health would have been 9%, the population would have been 9% healthier in 2010 than it was. If none of us had ever smoked and never heard of it, the population of the world would have been 6.5% healthier in 2010 than it currently is. So if any of you are smokers, I strongly urge you to give it up. High blood pressure, very important as well. It's not just a matter for rich countries. High blood pressure is very prevalent also in developing regions, particularly in Sub-Saharan Africa. Some important transitions in risk factors I just want to point out. Between 1990 and 2010, look at this, childhood underweight. When we measured it in 1990, childhood underweight, malnutrition, was the leading cause of disease burden worldwide, causing about 10% of global DALYs in 1990. By 2010, what on earth are we doing? It's the 8th leading cause. It's plummeted as a cause. Something is going right in terms of the global public policy response to reducing childhood malnutrition. It's primarily operating through pneumonia, measles and diarrhea. High blood pressure has gone from the 5th leading cause of DALYs worldwide to the 2nd leading cause. Dietary risks, now the leading cause. Tobacco from 4th to 3rd. So diet, blood pressure, smoking, household air pollution, and the 5th leading cause of DALYs of importance for you is alcohol use. Alcohol use causes not only organic disease, it causes accidents and injuries, it causes mental health and other conditions as well. So it hits on all the components of DALYs. Alcohol use has gone up 32% as a cause of DALYs, 32% over the last 2 decades. All right, I'll finish off by giving you just what I think are 5 higher order messages that come out of this massive 5-year, 1,000 collaborator, 1 billion estimate study. What did we really find out of this? 4 main transitions and 1 warning. Firstly, the demographic transition is shifting the burden from young children to adults. I'll show very quickly an example of each of these, so I just want to nominate them. Disease transition is is changing the composition of disease burden very rapidly in most parts of the world, from communicable to non-communicable diseases. And among non-communicable diseases, we include mental health conditions. There's a disability transition that's progressively shifting the burden of disease away from premature mortality to chronic disability, including the causes from mental health conditions. There's a risk transition taking place that's shifting the burden of disease from childhood conditions like malnutrition, vitamin deficiencies, suboptimal breastfeeding, through to those associated with lifestyle risks. All of this is true for the rest of the world. It is not true for Sub-Saharan Africa. What do I mean now? I'll quickly finalise then with examples of that. Shifting the burden from children to young adults. The green is the disease burden in 1990, the yellow, pale yellow, disease burden in 2010 by age. So males and females, the first 2 bars here, look at the huge decline in disease burden in males and females less than 5 years of age. Look at the increases in disease burden as we go into middle age, 15 to 49, and even into old age, greater than 70 years. So an important shift in disease burden down in the younger ages, up in the older ages, which is a good sign. A change in the percent of DALYs. This is the absolute percent change in the proportion of DALYs by country between 1990 and 2010 from mental health, from non-communicable diseases, including mental health conditions. So look, and red means that these countries, North Africa, much of East Asia, particularly places like China, Mongolia, Vietnam, Thailand, Philippines, all of Latin America, those dark reds mean there's been a 20 to 25 percentage point increase in the proportion of DALYs in those countries due to non-communicable diseases. This is a huge, huge transition. Blue means it's been very modest, and you can see South Africa and Zimbabwe being 2 of the countries where that is most important. This is difficult to see, but actually a very important graph. Between 1990 and 2020, we did the burden of disease for 21 regions of the world. They are summarised down here. And each bar is 100%. The part that's due to disability is in orange. The part that's due to premature mortality is in green. Can you see between 1990 and 2020 that green is going down, orange is going up, even at the back of the room, just broadly? So in other words, the contribution by region of disability to the burden of disease is going up. That's the orange part, and the premature mortality is going down. In fact, the lowest level is this 3rd bar here. This is Australasia, where now 55%, Australasia is Australia and New Zealand. I don't know about these New Zealanders, they're over there somewhere, but there's a big population here in Australia. 55% of the disease burden in this country, in Australia, I thought I was in Australia, I was last night. 55% of the disease burden in Australia is currently due to chronic disability, and only 45% from premature mortality, and that clearly is going down. Australia, New Zealand at the vanguard worldwide, but very closely followed by Western Europe, and here's North America, where it's about 50-50. Now, the thing that's not happening is in Sub-Saharan Africa, which is over on the right-hand side. You can see virtually all of those disease burden bars are green, meaning much of the disease burden, 70% or so, is still due to premature mortality. We've had an important risk factor transition. I won't repeat those, but we're now getting a much more nuanced understanding of the role of diet in preventing chronic disease, the leading causes. We've disaggregated that by 14 different components, and I've talked about this dramatic shift. Global rise in high body mass index. We're all getting fatter, and getting fatter is not good for health, and we're seeing the implications of that play out through chronic disease, including diabetes. I pointed out MDGs 4, 5 and 6 are still important in Sub-Saharan Africa. This graph shows blue in 1990, 2010 is in orange, the contribution of the disease burden by region just from MDGs 4, 5 and 6. Child mortality, maternal mortality, HIV, TB, malaria. If you just take those together, in Africa still, even though there's been some declines between 1990 and 2010, still 65 to 70% of disease burden in those regions arise from MDGs 4, 5 and 6. So as a global focus, that was the right thing to do, particularly in Africa. My last slide, just to try and tie all this together, because it's been a very, very quick tour, and Harvey's looking at me with daggers. The 5 sort of higher order points that I would like to summarise. Health-related MDGs 4, 5 and 6 are making an increasingly minor contribution to disease burden in much of the world, including East Asia and North Africa, except Sub-Saharan Africa and a few other countries, particularly Papua New Guinea, Afghanistan. There's been rapid and I'd say sustained progress in reducing child and maternal mortality over the last 2 decades worldwide. In 1990, 500,000 women died from maternal conditions. Today, about 200,000 do. So a huge decline in the right direction, the same about child mortality. HIV, TB and malaria, the Global Fund. HIV, TB and malaria each cause between 1 and 1.5 million deaths. It's no longer all about HIV. It's no longer those 2.5 million HIV deaths and a few 100,000 malaria deaths. No. TB, malaria, HIV, all equally important in terms of premature mortality today. A message for the Global Fund. There's an urgent need to promote policies and programs aimed at avoiding premature deaths of adults. We can't just as a global community keep babies alive till adulthood. We need to keep adults alive into old age, and we need to keep them healthy by reducing chronic disability, particularly from mental health and musculoskeletal conditions, as I'm sure your conference is going to address. And finally, just a point, you've all heard about the compression of morbidity, where some American scientists some years ago claimed that, well, we may be increasing life expectancy, so we're decreasing mortality, but we're also decreasing disability. And the global burden of disease results do not support that hypothesis. There is no evidence of a compression of morbidity. We're living longer, but we're living more and more of those years with chronic disability. Hopefully your conference will do something about it. Thank you very much.